Good afternoon, everyone. Welcome to the Performance Driven Academy. We are excited to have a webinar for you today around monitoring population health, keeping an eye on who we serve. And we have a couple of guests here that will be talking, and we're very excited to have their perspectives today. This series is brought to you by the Managed Care Technical Assistance Center, a partnership between McSilver Institute for Poverty Policy and Research and the Center on Addiction. I am Brianna O'Connor. I'm the Associate Director of CCSI's Center for Collaboration in Community Health. We are located up in Rochester, New York, and we're the upstate partner for the MCTAC initiatives. A couple quick reminders. If it takes you 2 minutes, that'll be a long time. It'll take just a second to fill out our 3-question survey about our last webinar so we can get some feedback about what you liked, whether the tool was helpful. That really will help us plan for the in-person events in December so that we know what additional information you need or how else we can talk about some of the strategic planning initiatives. You should have already received links to register for our last webinar and our in-persons that are coming shortly. I apologize, that date is wrong. Our last webinar is in November. The calendar will be populating in the last couple slides, so you'll see that, but it's sometime in November. You've already received a couple emails, and we'll be sure to send you a couple more. This webinar will be recorded. We will make sure that you receive the materials about this webinar. Our tool you already have access to, so we'll make sure you have the slides. If at any time you have questions or comments about what you're hearing today, please feel free to chat it in to all panelists at any time, and we will all receive it, and then we'll try to save a few minutes at the end of today to answer those questions. As usual, if you have any overarching questions or concerns, please feel free to email us at pda@ccsi.org. Today's topic is really covering the last of one of the last of our processes in our graphic about what it takes to become a performance-driven organization, and that is really how to monitor population characteristics and what are some important features you want to be thinking about monitoring as you're looking at your population. We're moving along on our road. We have one more webinar, our marketing and communications webinar coming soon, and then we have some in-person sessions that we'll be doing in early December, so hopefully we'll beat the worst of the weather. And then your Performance Driven Academy experience will be over, although we'll be sure to send you multiple emails asking you to send us your evaluation on a quick survey. You'll know about that. Just to set the stage before I turn the webinar over about why monitoring population characteristics can be really important. We talked a few webinars ago at the end of semester 1 about how to look at different outcomes within your organization by different demographic characteristics and how important that can be. But really thinking about broader, why should you be looking at your population, it's really, there's 2 kind of main reasons. The first is to really identify kind of quickly what's working or not working within your organization. So for those things that are working, you can see, okay, what do we need to expand? What do we want to try to adapt to other parts or programs in our agency? And then for things that aren't working, so that you can really identify something that isn't reaching the outcomes you want, isn't getting the impact that you needed, and so you need to shift course, stop that program, try something differently. The other main reason to kind of monitor your population as a whole is to really identify and address disparities that you might be seeing within your population. And it's almost a certainty, I hope I'm not over-speaking and I'll have Nancy correct me if I am, but it's almost a certainty that in the populations that you're serving, there are disparities. We know across the literature, across the research literature, that individuals that are not in our majority culture and that are non-white tend to have different outcomes in the health arena. So there's a few statistics here for you just to kind of set the stage for that. So compared to individuals that identify as Black, Hispanic, and Asian, individuals identifying as non-Hispanic whites are significantly more likely to be using mental health services, receiving treatment for depression, any kind, and receiving treatment for suicidal ideation and behavior, which when you flip that and reverse the phrasing means that those other populations are receiving less services, less treatment for those very severe mental health needs. We also know, though there's a lot less research about it, we know that migrant farm workers, which we know is a pretty substantial population in upstate New York specifically, in those rural areas, they're less likely to be using Medicaid-assisted opioid treatment, which we know is one of the most effective treatments that we have to help with opioid addiction. So again, just kind of a pattern across a large population where we know that they're not receiving the best treatment that we have available. In terms of some other kinds of different types of populations, individuals who identify as deaf, around 90% of them also have mental health needs that aren't receiving adequate services. So of those who are in need of them, 90% of them aren't able to receive them or aren't receiving them for some reason. And those are just a couple of snapshots. There's certainly lots of other research around some of these populations, but I think a really important point is also that there's very limited research about what behavioral health treatments are effective for a number of other populations because they haven't been studied. So we can probably assume that there are going to be some similar disparities in a lot of these areas, but we actually don't know what the impacts are because we haven't studied them as well as a society. So clearly there's some areas where we know certain populations are experiencing disparities in healthcare and some where we don't know much, which means that it's worth you looking at your organization level. So with that stage set, I will turn the webinar over to Nancy Shelton, who will be talking to you for the remainder of the content part of the webinar around monitoring population characteristics. And welcome, Nancy.
Thank you very much, and greetings from this brisk fall day here in Rochester, New York. I'm wearing my scarf because my neck needs to be warm. A little bit about me. The most important thing is I want to say hello and shout out to all my fellow ENFPs out there, and also that I have had extensive work experience in varied systems, and so I speak from that experience from my professional perspective as well as my personal experience as I am a member of the Global Village. Next slide. So today's learning objectives will include how we will define population health and how it can aid in the addressing of health inequities and disparities. We want to develop a common understanding of vulnerable populations, health equity, health disparities, and the social determinants of health. We want to also gain an understanding of who we serve and the best way to utilize individual and community data to inform service delivery enhancement. To adequately and better conduct the work of improving our performance from a population health vantage point, we must have a common understanding of these terms that we often utilize. So the first term is vulnerable populations, and vulnerable populations are identified to be at risk for health disparities. Specifically, they are unable to anticipate, cope with, resist, and recover from the impacts of trauma, illness, and disasters. Simply put, health equity is where everyone has a fair opportunity to live a long and healthy life. It implies that health should not be compromised or disadvantaged because of an individual's population group's race, ethnicity, gender, income, sexual orientation, neighborhood, or social condition. It's all about creating those fair opportunities, eliminating gaps in health outcomes, and as professionals, we should look for solutions outside of the healthcare system. We must incorporate the conversation regarding those social determinants of health. A lot of times we talk about everybody getting the same treatment, and we know in the world of cultural competence that that's not a conversation about fairness. From this diagram on the screen, you can see another view of the difference between equality and equity. In the first image, you see equality is about sameness, everybody getting access to the same thing. So you see the three individuals of varying heights having the same box to look over the barrier, which is the fence, so that they could view the game on the other side. And as you can see there, that the short person is not able to have access to the same experience. Equity is about fairness. It's truly a matter of social justice. Everybody gets their just due. What is it that every individual needs to access the same experience and enjoy the same quality? The needs of vulnerable groups are very different within those populations, and we need to think about them as we consider how we provide services. Sameness would not be sufficient where I may be in a health crisis state and you are in a well-being management state. I require different services and approaches to meet my needs. So this is the optimal desired state where there is no barrier present and everybody has access to everything that they need without any impediment. Barriers to achieving equity, we also must be aware that those barriers present as those social determinants of health. We talk a lot about health disparities, and health disparity is the inequitable health outcomes resulting from inequities in the distribution of or access to resources that promote good health outcomes. So you can look here and you can see adversely groups are affected who have been systematically experiencing greater social or economic obstacles to health care based on those different demographics, whether you're associated with a racial or ethnic group, your religion, your socioeconomic status, your zip code, your gender identity, and other characteristics historically linked to discrimination or exclusion. So I mentioned a couple of times the social determinants of health, and those represent in our conversation in achieving health equity and eliminating health disparities as barriers. And you can see in the middle there are the individual factors, and then moving out, there's individual behaviors, public services and infrastructure, living and working conditions, and social, economic, and political factors. For example, the root of racial and ethnic health disparities is racism, and racism plays into all of those different areas in the middle, the education of individuals, job opportunities, food access, socioeconomic status, environmental exposure, health behaviors, access to health services, safe and affordable housing, community violence and crime, and stigma. And as racism filters through those different areas in our community, they impact in a very negative way the health outcomes of those individuals. More than 100 studies now link experiences of racism to negative health outcomes. The experiences of racism over a lifetime can increase chronic stress levels. Increased levels of chronic stress are widely recognized as imposing serious health threats. The anger, anxiety, and frustration that result from experiences of racism trigger the body's stress response, which over time creates wear and tear on the body. Now let's discuss the work that needs to happen. Population health, I learned, was a term that originated in Canada. Hello, neighbors in Canada. And population health is an approach to health that aims to improve the health of the entire population and to reduce health inequities among population groups. In order to reach these objectives, it looks at and acts upon the broad range of factors and conditions that have a strong influence on our health. On the next slide, I love this elucidation of the term of population health, and it's just saying that population health is the notion of health as a positive concept, signifying more than just the absence of disease. It is a state of complete physical, mental, and social well-being. That sounds just lovely to me. So I love that this whole, the way that it's broken down here, that it's very strength-focused and focuses on individual self-determination and gives the power back to the patient and consumer. Population health and inequities, given that health inequities are pervasive in the United States and widely acknowledged, the challenge is to identify what causes them, and purposeful metrics should provide knowledge for understanding the root causes of these disparities. From an analytic perspective, thinking about measuring the drivers of health inequity requires thinking about equity across specific domains. Health disparities across neighborhoods exist for a variety of reasons listed here on the screen. Again, are represented among those categories within our social determinants of health. We need to connect the dots. And what are some barriers to achieving health equity as listed above? To serve, we must know who needs what and why. Remember, our task is to remove barriers to create equity. Who are the community? And if you would indulge me, I like to use community and populations interchangeably. So for the purpose of my conversation, I will speak from the community perspective. So populations/community is defined by people, place, affiliation, and identity. We must know the community in order to serve them. Understanding the community that your patients, consumers live, work, play, and worship in These are critical questions that you want to ask. What is the history of that community? What are their traditions and norms? What are the community demographics and the trends? What are the community's specific interests, needs, and assets? And we need to assess the community profile. Utilizing the outcomes visualization tool will help you to collect the data that you need in order to give you a view into what's happening within your organization to address population health. You can identify existing or emerging disparities among certain service users from the view of gender, ethnicity, race, age, and language, all while connecting those variables to service utilization and outcomes. This chart right here also gives you some cultural attributes that you may want to consider to collect, broken down by different high-level views. So you want to collect the information of the service population as it relates to their identity, their language and literacy, their origin, and the social determinants. And some of the things you may not necessarily consider, but are critically important if we want to be a member on the team of trying to help a patient or consumer achieve their own definition of wellness, are things like spiritual practice, understanding language beyond just the fact that I don't speak English, that there are some colloquial, vernacular, or regional language that needs some translation sometimes, the use of homeopathic remedies and spiritual practices associated with complementary, holistic, and indigenous practices, and just also thinking about what use of services that were utilized previously, and poverty. Poverty is a big one, and the impact of poverty in helping individuals achieve their desired outcome. This next diagram illustrates the difference between the determinants of population health and the determinants of an individual's health. The determinants of population health looks at rates and averages and distributions, whereas the determinants of individual health looks at risk factors. These two things, population characteristics, affect outcomes independently of the characteristic of individuals. However, we must obtain a full view from both perspectives. This view will optimize our effort to achieve those desired outcomes. So we have a common understanding of key terms in our work to improve population health. We possess the awareness on why and how to collect necessary information of the community that we serve. Now, what do we do with all of that information? Well, we base our decisions on that data. We can draw on a variety of data, both qualitative and quantitative, from different places. The data that we should try to think about at a minimum is patient consumer information and demographics, environmental data, lifestyle data, vital statistics, social and economic data, epidemiological data, health system data, and patient consumer information and demographics. Where do we get that information? Well, some sources that we can collect it and store it on is on the outcomes visualization tool, but we can collect that data from our census records, community health needs assessment, county health improvement plans, regulatory system entities, funder reports, school districts, etc. But if you really want to kind of get into the cultural attributes of an organization, we may want to consider collecting some data from some non-traditional sources, like from civic groups and social clubs, business associations, professional trade organizations, neighborhood groups, the faith community, the Chamber of Commerce, Farm Bureau, individuals impacted by your services. One source of great information I recognize in the rural community is the Rod and Gun Club and the different VFWs. They collect information on their members as well. Once we, as organizations and professionals, have collected, monitored, and analyzed the data, we can perform more culturally informed service delivery. Some issues to consider in our ongoing effort to rise to cultural proficiency are to consider recruitment and retention of ethnic groups in research, paternalism and institutionalized racism in regards to those who cannot afford best practice, and cultural differences between health professionals and patients in their understanding of best practice, health, and illness, which is called cultural incongruence. The reality is oftentimes when we work with individuals, we come from a different perspective, and we may not be representative of the culture of the person that we're serving. And often our culture is not in sync with the culture of that patient or consumer. So how do we cross that cultural divide to provide great service? At the core, employing cultural humility with the awareness that I don't know what I don't know. Some culturally informed strategies that reduce cultural incongruence include culturally competent patient-centered approaches, health literacy universal precautions, patient activation, motivational interviewing, racial and ethnic trauma-informed practice, anti-oppressive practices, shared decision-making, and the development of a cultural knowledge system to improve services and outcomes. We must intentionally manage our own biases and the imposition of our worldview on others as we interact with our service population. The notion is that the patient-consumer community are the expert on themselves. Community-defined practices is a set of practices that communities have used and determined to yield positive results as determined by community consensus over time, and which may or may not have been measured empirically, but have reached a level of acceptance by the community. The CDE includes worldview, contextual aspects, and transactional processes that do not limit it to one manualized treatment, but it is usually made up of a set of practices that are culturally rooted. Include, very important, do not dismiss practices that have been effective and work in cultural communities. Yes, we need to document, collect data, and evaluate approaches in a culturally responsive way and validate the work of those who have been successful in producing those desired outcomes. Cultural competence and adaptations is a method in which we could improve our service delivery by being responsive to the needs of those we serve. It is the ability to provide services that are culturally relevant and appropriate to families and their loved ones as detailed by the people that we serve. Cultural commonalities can be helpful when taken in consideration when planning those services. To set yourself up to serve culturally diverse populations, you must first seek to understand them, and you do this by collecting that cultural data. Utilizing a cultural assessment on all patients and consumers and their families. Then you can adapt service approaches to the language, cultural norms, and individual preferences. Your organization should foster and value diversity. You should be compelled to educate members of the team regarding the cultural information that you've collected. You want to identify and address disparities in care, access, and quality for diverse individuals. And you want to intentionally develop collaborative relationships with other providers of services that have been tailored to the needs of culturally diverse consumers and their families. And once you have done this, you are better equipped to base your choice of practices and approaches on cultural match of practice approach to the population that you're serving. You can create cultural adaptations based on fundamental cultural worldviews of that population. And in research, at a minimum, use proportional representation of ethnic racial groups in standardization samples of sufficient size to be statistically significant for each group to be able to make that cross-group comparison. Where does the solution lie? Well, it may lie to improve outcomes, may lie in the cultural and ethnic frames in which population, community, and individual see itself. Gaining that understanding of the individual and incorporating the cultural nuances will aid us in achieving health equity. By enhancing communication and service delivery to better support those individuals, those communities, those populations to achieve better health outcomes. So what's important? It is much more important to know what sort of a patient has a disease than what sort of a disease a patient has. So in summary, we discussed the development of a common understanding regarding vulnerable populations, health equity, health disparities, and the social determinants of health. We define population health, addressing health inequities, health disparities, and the social determinants of health. We have determined some important characteristics to consider of the individuals and the community you serve. And we identified a few ideas on how to utilize individual and community data to inform service delivery enhancements. Now I pass the microphone to Brianna, who will talk about a tool you can use to aid in your discovery.
Thank you, Nancy, for that great content. What I do want to remind everybody is that you already have a tool that can do a lot of these things for you. So we've shared with you before, and it's available on the CTAC website, our data visualization tool. And we looked at that tool and some of the data that it can provide for you, and I'll show you in a couple of slides looking at, reminding you what that looks like. But just to remind you that this tool is actually very modifiable intentionally so that you can look at whatever populations of interest there are within your community. As I always say, whenever I'm talking about collecting data, we're not saying that you should collect just to collect. Nancy gave you probably 100 different things that you could collect on any given population, and certainly you need to be able to select kind of carefully what you are going to be collecting or looking at if you already collect it. So you really want to consider and, of course, ask your consumer base what are the characteristics that are relevant and important within your community that you serve. Any of those populations or characteristics that you select, the tool will actually display for you if you enter it in one of the columns, or kind of modify the tool a little bit. So you'll be able to look at different patterns of service utilization and outcomes by those different characteristics within the tool that we've already created. We've talked before about looking at a particular outcome or a particular utilization pattern by one characteristic is valuable, but being able to look at it by multiple characteristics at the same time so that you can see not only a difference between women and men, but a difference between women who identify as Asian, women who identify as Black, women who identify as white is much more rich information. So this tool does allow you to do that. And then also make sure that whatever you decide to collect and populate into this tool or another similar tool is something that you can do something with. So a couple of the suggestions that Nancy shared about, you might want to look at someone's, look at your population's education levels, immigrant or migrant status, preferred language, all of those things. You can do something with those. You can see if you need to edit some of your materials, provide translators for different populations. You might want to use that information to structure your staff recruitment efforts to make sure that you have staff that are representative of your population served. And then, of course, as I mentioned in the beginning, you're inevitably going to find disparities, unfortunately, in our healthcare system. And so you can use this information to identify disparities that you want to address with a quality improvement initiative that will be informed by some of those consumers and some of that community that Nancy described, to really tell you what are the barriers, what are the challenges, what are the issues for that particular population. And using this tool, you'll be able to see over time whether that disparity has decreased or the outcomes have improved for that population. If you need additional support with how to modify this tool, we have put out at the suggestion, recommendation, request of other Performance-Driven Academy participants, a series that's actually currently underway. I think they just did their second of three, but they're, of course, recorded. We have a business intelligence series that David Wozniak, who's a CCSI senior consultant, has been putting out through MCTAC. You get them on the main MCTAC listserv, and then we also send you a follow-up through the PDA. But that is really him walking you through the hands-on tools that are underneath some of the tools that we create for you. So how to use Power Query and Power Pivot and all those technical things that help you take this tool and really tailor it to what your agency needs to be able to look at the populations of interest and the outcomes of interest for the work that you do. Just a couple of slides just to remind you what this tool looks like and what it can do for you. So this is an example of one of the pages that will report out for you some of the demographics that are already in this particular sample data set. So here they're looking at age and gender and a bunch of other things when you scroll down, but there's also filters available for ethnicity and race as well. So you can make those are what I'm referring to by the filters, that you can tailor those to any characteristic that is salient to your community. And then you'd be able to take a look at the outcomes that you're looking at by those same filters. So for example, if you're looking at severity of symptoms on a particular measure, you can filter that and take a look at the difference between female Hispanics 6 to 12-year-olds compared to female Hispanics 13 to 17-year-olds, or any other combination of those filters that you would want to look at to see if you have disparities in those outcomes. And you can also do the same thing with the service utilization, so you can see if there's differences in which services and how many services various populations are using. So hopefully it's a pretty powerful base tool. Certainly needs a lot of customization based on the suggestions Nancy was providing around what to collect, but hopefully that gives you the flexibility to get what would be important for your population. I'd like to turn it back over to Nancy to introduce our guest and hear a little bit about an agency who's been working with these types of questions and thinking about the types of data and culture that are important in her community.
I am so honored and delighted to introduce to you all Valerie Way, who comes from East House, and she is the Vice President of Programs at East House. And I had the privilege of working with her and her Cultural Competence and Health Literacy Committee there to really kind of delve deep into this conversation that we presented in today's webinar. And she's going to tell you a little bit about what's happening over there at East House. Thank you so much, Valerie, for coming, speaking with us today, and looking forward to hear what the good news that's happening over there at East House.
Thank you, Nancy. Hello, everybody. For those of you who don't know, East House is a nonprofit organization in which we provide residential and recovery support services to adults with mental illness and or substance abuse services. We serve Monroe County, which is the Rochester area. And as you may suspect, we serve many of the vulnerable populations that Nancy mentioned earlier. So primarily our population are those receiving Medicaid services, economically disadvantaged. We have a diverse ethnic and racial mix of individuals. However, I would say primarily the larger portion are folks that are white, non-Hispanic. We do serve individuals who are deaf and hard of hearing, being in the Rochester community. We certainly focus on housing and folks who are homeless or are housing unstable. And again, as we learn through our collection of information, our data, we certainly serve people with all types of different mental illness diagnoses, substance use diagnoses, and physical health conditions as well. I have to say that we have been working on data and our understanding of data and our understanding of our population that we serve and how we fit in the community for several years now. It has been an evolution. I would say that first we needed to take a hard look at the elements that we collect on a routine basis. And, you know, when we did that, we certainly found that there were gaps in understanding the population that we served. One example of that was sexual orientation. And so we added that to our demographic profile, and we've begun now getting some demographic reports on the population served. You know, we've hired a IT analyst and a specialist who works with our electronic medical record, and we needed to really understand the definitions of each of the different data points that we were putting in our electronic medical record, and needed to understand how that all fit together. He was able to begin generating reports for us so that we could see where the gaps in data were in our system. And again, our staff started filling in those gaps so that we really felt confident that our data had integrity, so that as we were using the data, we felt confident it truly reflected the population we were serving. You know, and I guess the other thing I would say is we're really we've moved past all of those different points, and we're really at the stage now that we're starting to take a look at multiple characteristics, which is very exciting to me. So some of the things that were previously discussed is, we're starting now to look at, how to layer that data, if you will, and look at different combinations of characteristics to better understand our population. So I'll share with you a little bit some different examples of how we've used data, both community data as well as our own data, to continuously improve our services at East House. The first example is we provide housing services, and we have embarked in the last couple of years in building housing services. And so as we seek funding for housing, we had to obviously take a look at what data was available in our community. We looked at Medicaid data from a New York State level, a Monroe County data. Many of you may know that Rochester is one of the poorest cities comparable to its size in the country. We used data from our continuum of care on the homeless population and learned that single individuals with mental illness and addiction were more likely to be homeless or unstably housed. So it really led us to justification for the building or the need of affordable housing. So we've been able to build additional resources in our community for that population, and again, having an impact on the community. Our experience has been that people have done better as a result of having stable housing. They're less likely to go to the emergency room, have hospitalizations, be incarcerated. They're moving forward in their lives in the area of work and social connectedness, et cetera. But that's just anecdotal, and so what we're really trying to focus on right now is trying to back some of that up with our data. So some of the work that we would like to do is take a look at some pre and post data of individuals who maybe had unstable housing previous to coming into some of these new housing environments, and how have they done. And we could take a look at Medicaid and as well as how they've been functioning in their community as a result. So that's one example. A second example is we have a centralized admissions department, and our admission department is very well connected to what is happening in the community. And what we're seeing in our community in Rochester is an opioid crisis, much like what is happening around the state. And what we've been able to track is we get 4 times the volume of referrals to our OASIS licensed housing programs than our mental health licensed housing programs. However, when we take a look at our admissions, only about 1/3 of those referrals actually get admitted. So we began to try to understand the data, try to understand what was happening to the people that were not coming through our doors. And that really led to different interventions at a community level, at an agency level, as well as individual level. We also started tracking the diagnoses, and we began looking at how many of the folks that were coming in or being referred and admitted into our program had an opioid diagnosis or fentanyl use. And we really began to track those specific diagnoses because we've seen actually a significant increase in the last couple of years. And so as a result, we needed to change our practices. We needed to really look more critically at those referrals and those individuals, how we were going to provide them quality care, how we were going to put additional support around them when they did come into us for service. So one of the things that, again, what we'd like to do moving forward is being able to stratify some of the referrals, the people who are not getting into our services. We'd like to stratify that information more with some of these other characteristics: gender, age, zip codes, perhaps diagnoses. And so again, it just will allow us to tailor our services or even create additional services for that population. A third example I can share on how we've used data is through our quality process. And we do quite a bit of incident trending. For an example, we've had some we opened up a level of housing services in the last couple of years that's new for us. And what we have found, it's about 2 years old now, and what we found is that the folks that tend to get admitted to that program are more medically fragile, have more physical health conditions than some of our other populations that we serve at other locations. And so, again, we've needed to take a look at that. We had some individuals who were falling, and so we learned of this through our incident management tracking process. And so, again, we've been able to, on an individual basis, follow up in the care, make sure that people are getting the quality care that they need. We've helped people transition to maybe other more appropriate housing environments, but we've also been able to do training for staff and put other kind of service supports in place because we have recognized that that is a more medically fragile population. Also, through our incident trending, we track individuals who have emergency room use or frequent hospitalizations. And so again, that's a high-risk population that is very important for us to be tracking and intervening with. We want to make sure that as people return from the emergency rooms or from the hospital, that we're providing additional support for them. And so by tracking and trending that information, we actually review them on a weekly basis, amongst all of our housing directors to ensure that enhanced support and follow-up is happening. One of the things that we'd like to do moving forward is looking at folks who have had suicide gestures and attempts, and again, looking at is there a specific program that they tend to be affiliated with or living at, again, age, gender, diagnoses. Those are things that we want to get our arms around a little bit more. And I guess the last example I would share is an example of how we understood our population at East House. As I mentioned, we work with adults with mental illness and addiction, and many of the folks that we work with have many characteristics of metabolic syndrome. They're overweight, they have high blood pressure, high cholesterol. Many of are taking antipsychotic medications that increase, that medical profile. And so we wrote a justification and a need and obtained grant funding to implement a diabetes prevention program. but it wasn't a traditional diabetes program. We adapted it. And so we adapted it for our population in that we broke out some of the sessions, we enhanced the opportunity for peer support, we enhanced opportunities for social connectedness, and we really reduced the intensity around the data monitoring because, again, what we found was that our population tended to shy away from participating in programs when that was heavily focused on. We also provided assistance with transportation and whatnot, and so these are all adaptations that we made to the traditional DPP program for our population. So, you know, we have, at East House, we have ongoing ideas on, you know, the data that we're collecting and understanding and getting in, and it is leading us to different quality improvement initiatives and ideas. So I hope those examples were helpful.
Thank you, Valerie.
Yes, thank you very much. I think it's always really great to hear about really rich examples of how you're actually able to implement some of these things and, like you said, make some changes and really identify some needs in your population. So thank you for sharing some of those. While I go through the last couple of slides, I'd like to remind all of the audience that if you have any questions for either Nancy or Valerie, now is the time to chat them in to all participants. We will have a few minutes to ask questions, so please send those over. With all of our webinars, we like to talk about a couple of concrete next steps of things you can do to really start to take action on what you've heard today right away. It's a small step. It's not getting at everything, but it's really to start to think about some of these things. So here are some takeaways for you today. Certainly one would be to revisit the data visualization tools that you already have access to, or any other reports that your organization is currently using to monitor some of those population characteristics. And within your work group and other kind of key representatives and stakeholders, really kind of consider, are we looking at the key characteristics for our community? Do we know what those are? And if we know what they are we looking at them? Are we able to look at those patterns with multiple characteristics in mind? I use crosstabs, and I think Valerie used like layering. Whatever words make sense to you guys. Are you looking at multiple characteristics at the same time to identify really, again, kind of rich patterns about the folks that you serve and how you can serve them in a better way? Another takeaway, another kind of easy start point would be to talk to some of your consumers about what elements of their identity are really important so that you can kind of prioritize what to collect or what to look at in terms of your community served. If you aren't collecting some of those pieces of information, then it would be a conversation again with your work group first to really think about, should we be collecting these? Are there other ways we can go about it? Or, you know, my preference is always, is there maybe not your first choice, but maybe a second or third choice piece of information that you are already collecting so that you can lower the resource burden and start to make use of some of that information first and get your hands kind of dirty that way before collecting a whole new set of information. Please also be sure to mark your calendars. We have one more webinar coming up November 14th. This one will really be about marketing and communications. So it's really talking about how to package all of your efforts in the performance-driven world. How do you talk about your impact, what you do, how you do that in a very financially beneficial way, and really market that out to various stakeholders and communicate that to potential consumers, referral sources, funders, MCOs, whatever stakeholders are important for your organization. In early December, we have 3 in-person events set up already. Again, those links to register for those have already come out. We do ask that you each individual person register so we know how many lunches and coffees to plan for. But please do bring your work team for those. We'll be sending out an agenda about those in the next few weeks so you know a little bit more detail about what we'll be covering in those sessions. Those are in our usual locations in Albany, Rochester, and New York, so we hope you and your work team can join us for those. at those in-person sessions, we'll really be digging into a little bit more detail around some of the characteristics some of the webinars that we've covered in the last couple sessions. So really talking about strategic planning, how do you incorporate thinking about your population, and how do you use what you've done so far and what you do well in your organization to really market that out. So really digging in a little more hands-on way at this in-person around kind of strategic planning and thinking forward about all of the things you've learned in the Performance-Driven Academy. How do you keep that momentum going? A lot of you have been joining us pretty regularly, so certainly this is an investment on your part. So how do you keep that momentum and keep the changes moving? With that, one last plug to ask any questions that you may have for our speakers. Chat them in now while we have a couple of moments to ask questions. So one question I have, if you could both maybe offer your thoughts while we're waiting for others to potentially chat something in, is this is a lot of information. There's a lot of places to start. There's a lot of things to collect. And Valerie, you talked about a lot of different initiatives within your organization. So I'm wondering if you could offer some suggestions for folks who are thinking this sounds a little overwhelming, this sounds like a lot, there's already a lot going on, about where to start and how to make that kind of seem like an achievable thing.
Well, my suggestion would be, as I mentioned, I had opportunity to work with Valerie's committee that's focusing on cultural competence and health literacy within our organization. I would suggest that you establish something like that, where there's a concerted view and a dialogue regarding how to best meet the needs and market to and engage with those vulnerable populations in your community as a whole. There are resources among the folks sitting at the table who are represented in your staff, because they come from the community as well, but also you want to intentionally include the patient consumer voice at that level so that you can test what you think you know with the reality of the people you intend to serve. So establishing a committee whose concerted task is to conduct the work of understanding the people and the characteristics and the cultural nuances of the individuals you serve, and then determine how best to collect that information, utilize it to improve service delivery.
Yeah, and I guess from my perspective, I would say that many organizations are involved in continuous quality improvement initiatives in one way or another. And so rather than feeling as though you have to start something totally new from scratch, what's a quality initiative that you're working on already that perhaps you can just maybe do a deeper dive around and understand, from a maybe a cultural lens or perspective. And I think that's some of what we've started doing is not necessarily feeling like we have to start something totally new, but maybe just build on things that we're already working on.
Mm-hmm. That's a great point, Valerie, because I think a lot of times we don't celebrate the stuff that we're doing well. And so, and there is merit in the work that you've already put in. And also, to maximize your resources and your dollars, you don't need to recreate the wheel. But also go out to the community and see those best practices that are occurring among your peers and colleagues, and also complementary organizations and programs, and you can kind of, lack of a better word, steal their good stuff and implement it in your own respective space.
Great suggestions. Thank you both. There are not any additional questions that have come through, so I will thank everyone for their time. I really appreciate Nancy and Valerie sharing their perspectives and their time today, and everyone listening. Thank you for joining us, and we will chat with you again in November, and have a great afternoon.